other
Good evening, everyone. How are you all? Good evening, everyone. How are you all? So welcome to First Aid AMC MCQ free 2-week sessions. So far we did discuss a lot of things, and you are getting some ideas about how we take our sessions and all. I'm hoping that you are liking our sessions so far. So today we are going to finish cardiology. We would not be able to finish the full cardio because we will still have ECG class. And ECG class is a part of the course. So we will do that when the course class starts. But mostly it will be finished today. Now, throughout this 2-week session, we discussed psychiatry. We did also a question solve tips and tricks. You had 2 random question solve classes. And then we did a cardiology class. And then tonight is the second class on cardio. And our idea would be to do a cardiology question solve class next time, right? So I hope that you have seen the schedules. So we'll just go along with that. So I was saying the other day that if any of you want to join the session, so the course admission is going on at the moment. So if you're still waiting to join, or if you still want to go on with the free 2-week session, my advice will be like, it is more than enough for you to understand how we take our sessions by now, because there is a lot of classes we have taken. So far you have, if you like the session, it means it is a good course, or this is the course for your benefit, and you should start the enrollment, because like it takes some time to do the enrollment process, give you the access to the portal and everything. So it's a good idea to start the process this week, so that once the course starts, you don't need to wait to get into the course. Okay. So any questions from our last class on cardiology? According to John Murtagh, stable angina pain is less than 5 minutes. So usual duration is 3 to 5 minutes, but up to 15 minutes, we can consider stable angina. That is right. It is given in some other guideline like Kaplan, but according to John Murtagh, it is 3 to 5 minutes. And when patient presents with acute angina, do we give GTN or aspirin if both are in the options? Patient rarely comes to us with acute angina, because patient can't come within 5 minutes to you. So this type of question will not come to you. And angina patients, usually they will be advised to get GTN first. So they usually have a GTN spray with them, and they will usually just do the spray or put a tablet under the tongue. So very unusual that angina pain will come in the exam like that. There will be another ECG class in the course, and that's it. Today we'll finish most of it anyway. So ECG is a part of the course class. So once this 2-week session is over, then we will start it. thrombolysis is a medication where you give thrombolytics like streptokinase, the tissue plasminogen activator. It dissolves the clot. It's a medicine which dissolves clot. And PCI, not PCA, PCI is a intervention. So you put a catheter into the groin, and then catheter goes into the coronary artery, and then you put a stent in. The reason why we don't give clopidogrel is because it's not it's not given if a patient requires a surgical intervention, because it is more stronger blood thinner. Once the PCI is done, then yes, we are going to add clopidogrel when they discharge to home. And Dr. Homa, we will discuss ECG, and then you will know what is inferior, anterior, all the MI. Thrombolysis and PCI, we discussed about that. The last class was fully about PCI and this thrombolysis. So no point of discussing this again. Otherwise, we will not be able to finish today's class. Did you do our last session, Dr. GJ? Yes. So I don't understand. So both of them. So, all right, let's discuss. So normally you need to do thrombolysis and PCI is both appropriate if a patient comes within 12 hours of symptom onset in a ST elevated MI. So if PCI available, you will go for PCI. When PCI is not available, then we go for thrombolytics. Perfusion test is for patient who has stable angina. Okay, moving on. So we will come back to if you have any questions, we will come back at the end. We will again discuss any questions you have. So let's move on. There's a lot to discuss in cardiology theory class 2 as well. Okay. The lecture notes are updated. So whenever we give like any lecture notes that is given in your portal, those are updated lecture notes. Sometimes time to time we add more slides into those existing ones. If we add any new slides, if we update any new things, if there is any new guideline, so then it will be updated anyway. So the guidelines that is there already, especially the theory lecture notes, those are all according to John Murtagh 8th edition. So these are all updated. Okay. Yeah. So if you go for AMEDEX 2024, that is enough. So today's class will start with congestive cardiac failure. Very, very important for exam. So CCF means that your heart is not pumping enough blood to meet the body's needs, right? So we did discuss a little bit about cardiac pathophysiology. I hope you remember. So quickly we will discuss, because that is really important to understand what are the symptoms of cardiac failure. So if you remember, we discussed that so from superior vena cava and inferior vena cava, blood will come to the right atrium, then it goes to the right ventricle, and then through the pulmonary artery, it will go to the lungs. Sorry for my drawing. And then in the lungs, this deoxygenated blood, so all of these are deoxygenated blood. So deoxygenated blood will be oxygenated, and then it will be carried by the pulmonary vein. And pulmonary vein will carry the oxygenated blood. So it comes to the left atrium, and then it goes to the left ventricle, And then we have got the aorta through which all the blood goes to our body from the left ventricle. That's how the heart physiology works. We discussed in more detail in our last class. Now, this is really important to understand the physiology of cardiac failure as well. So, cardiac failure has been divided into multiple subdivisions. So, it could be left heart failure, it could be right heart failure, it could be systolic heart failure, it could be diastolic heart failure, right? So, when a patient has heart failure, they can present in multiple ways. So most common heart failure is left heart failure. So let's say someone has got myocardial infarction or someone has got severe hypertension. So something which is causing weakening of this left ventricle. So when even sometimes severe aortic stenosis. So any of those, when your left ventricle needs to pump the blood against a lot of pressure, what happens is that the left ventricle, the muscle will start to become hypertrophied because it is, let's say there is a narrow valve here, aortic stenosis, or there is high blood pressure. So against the pressure, when heart needs to pump, it needs to do more activity. It needs more strength. To do that, heart starts, especially the left ventricular muscle, becomes hypertrophied. When it becomes hypertrophied, it loses its elasticity. So it becomes kind of like a flaccid muscle, right? So what happens at that time that it can't pump blood anymore as effectively as it should. So let's say that the left ventricular hypertrophy, and at some point this elasticity of the left ventricle is no longer there. So your patient developed left heart failure because now the contractility or cardiac output is no longer good. Cardiac output means that every time there is a systole, the heart will pump blood into the aorta, right? So every time there is a contraction, then from the left ventricle, blood will push towards the aorta. This contraction is called systole. And when contraction is done, heart will relax and then heart will get filled with blood, which will come from this both end. And that is called diastole. So diastole is the relaxation part of the heart and systole is the contraction part of the heart. So let's say your patient has developed left heart failure. So at some point, there will be more and more blood accumulating on this chamber. And then the left atrium will start to get overflowed. So there will be more and more blood in the left atrium. At some point, the lungs will start to get fluid accumulation, right? Because it is getting backflow, because the heart is not pumping enough blood. So there is all accumulation of blood. And at some point, there will be fluid accumulation in the chest. And that is the time a left heart failure patient will start to get shortness of breath on exertion. They also get orthopnea. And orthopnea means when they lie down, their shortness of breath get worse. Why? Because when the patient lies down, it is now because of gravity, all the fluid starts to accumulate in the lungs and they get more short of breath. Sometimes they get very short of breath that they need to just get up in the middle of the night and they need to catch up for breath, which is also known as paroxysmal nocturnal dyspnea. So all of these are features of left heart failure or left ventricular failure. When a patient develops orthopnea, and you can hear bibasal crepitation on auscultation, so bibasal crepitations, that means the patient has developed pulmonary edema due to left ventricular failure. Okay, making sense? So initial thing starts with that heart is not pumping enough blood, so left ventricle is weak. Could be that there is a myocardial infarction and this part of the heart muscle is not working well, it is weak, so that's why it is not pushing well. So whatever the reason is, when left ventricle cannot contract well, cannot push the blood into the aorta, there will be backflow or there will be regurgitation of blood. And at some stage, there will be fluid accumulation into the lungs, which will cause pulmonary edema due to left heart failure. And patient with pulmonary edema can present with shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, and on examination, you can find bivasal crepitation. Did it make sense that how this left heart failure works? Everyone clear? Because we can't come to like discuss this again, okay? Because repeating this, it takes a lot of time. Good. Now, as we can see that, let's say at some stage, the lungs will get filled with blood, filled with fluid or blood. So what will happen? The pulmonary artery will start to get backflow. And when there is a lot of pressure in the pulmonary artery because of fluid getting retention, it will cause pulmonary hypertension, right? Now, we have pulmonary valve here. So think about that this is a high pressure area now. To push the blood into this pulmonary artery, the right heart now needs to work harder because there is a lot of pressure in here. Now, to do that, right heart starts to have the hypertrophy, which becomes right ventricular hypertrophy. In the same way, at some time, right heart will fail. When right heart fails, there will be accumulation in right ventricle, backflow into right atrium. So more and more blood getting accumulated in the right atrium, which is when the central venous pressure will be increased. And now we can say that because lots of pressure in here already, blood can come from superior vena cava or inferior vena cava easily anymore? No. Because if something is full already, the blood will not be able to come here, right? So what will happen that SVC, like superior vena cava, will start to get fluid retention. IVC will start to get fluid retention. So when there is superior vena cava is getting fluid retention, that is the time you will get raised jugular venous pressure. So JVP will be raised, right? So that's one of the feature of right heart failure. If you remember, what will happen because of this retention in the IVC? For inferior vena cava takes blood from your lower leg. So lower leg will have pedal edema. IVC also takes blood from the portal vein or hepatic vein. So those veins will also get accumulated with fluids or blood. What will happen? Congested liver. And that's the time you will get tender hepatomegaly because there is a lot of fluid there. Okay? See that everything is making sense now, right? Like you have memorized all of these symptoms and signs throughout years and years, but this is how this usually happens. So we have got raised JVP, we have got tender hepatomegaly, we have got pedal edema. Okay, and that is the main feature of right heart failure. So basically, there is a way to differentiate between left heart and right heart failure. Left heart failure will come to us with shortness of breath on exertion, mainly orthopnea, and bivasal crepitation is the main feature. On the other hand, right heart failure will come as raised JVP, tender hepatomegaly, and pedal edema. But you can understand from one of the things that the cause of right heart failure is actually left heart failure. So sometimes question asks, what is the most common cause of right heart failure? Actually, left heart failure is the most common cause of right heart failure. Okay. Yeah, so orthopnea is very specific for left heart failure. Without left heart failure, orthopnea is unlikely. And when pulmonary hypertension, so when there is lots of fluid accumulation in the lungs, then there will be the pulmonary artery will start to get accumulated with bloods and fluid. So there will be retention or backflow into the pulmonary artery. Okay. So that's important to understand that this, if you understand this, you understand heart failure very nicely. Okay. Now, this is right and left heart failure. We also need to know that what is diastolic and systolic heart failure. As I was just discussing a little bit, systolic heart failure means that when a patient's systole is impaired, when contraction of the left ventricle is impaired, that gives systolic heart failure, which can be due to a lot of causes like myocardial infarction. It can be like if a patient has got, like, let's say, cardiomyopathy. So lots of condition is there, hypertension, AS. So systolic heart failure, most common cause is myocardial infarction or ischemic heart disease because that causes weakness of this muscle. Same, that diastolic heart failure means that when heart is not relaxing enough. So heart needs to relax to take all the blood in, right? If there is no blood in the heart, how can it contract blood? So when a heart loses the capacity to relax, that's the time it causes diastolic heart failure. Okay? It's not always. Right heart failure can happen independently. Like there are conditions called cor pulmonale, where patient has some lung condition like emphysema, COPD, and because of lung condition, they develop pulmonary hypertension and they develop right heart failure. And that patient doesn't have left heart failure. So it can happen without left heart failure as well. The, the systole is contraction of the heart. So it's contraction of both, not just the left ventricle. The contraction is both. When systole happens, blood will rush to the pulmonary artery as well. So it's just like the whole thing. Okay, so if cardiac output is reduced, so cardiac output means that the amount of blood left ventricle is able to pump into the aorta, let's say, in a very simple way. If cardiac output is impaired, ejection fraction will be impaired because ejection fraction depends on the cardiac output. So the idea is that if a patient has loss of contractility or if the systole is impaired, cardiac output will be impaired. If cardiac output is impaired, ejection fraction will be impaired. So that's the reason why in systolic heart failure patient, you will see that their ejection fraction is less than normal. And that is why we need to get the ejection fraction to differentiate between a systolic and diastolic heart failure. And how we can get the ejection fraction? By doing an echocardiogram. And that can confirm our diagnosis of heart failure as well. So like in this case, you can see a 60-year-old man presents to his primary care physician for several months of dyspnea on exertion, exercise intolerance, lower extremity swelling, past history of sarcoidosis. He has JVP elevated, pitting edema. So we can understand from here that this is a heart failure patient, mostly right heart failure, or can be just a congestive cardiac failure. Echo says ejection fraction is 35. Normally, ejection fraction more than 45 is normal. Okay, so this is less than 45. So even by looking at it, we can understand that this is a systolic heart failure because the ejection fraction is less than normal. Yes, congestive cardiac failure means both heart failure, and congestion means when there is fluid accumulation. Without fluid accumulation in the body, we don't say congestive cardiac failure. Okay, so what are the symptoms of heart failure? We already know that. So dyspnea, orthopnea, patient will get very fatigued and lethargic. Some of the patients can get dry, irritating cough at night. Because of fluid accumulation, they can have weight gain, ankle edema, abdominal discomfort because of hepatic congestion. So these are common symptoms. We know that. And we know about what are the presentation of left and right heart failure. So these are all good. We discussed that. If you want, you can go through this video. It also gives an idea what is systolic and diastolic heart failure. Okay, so systolic versus diastolic heart failure, right? So the classic heart failure is systolic failure because that's usually the main reason. And systolic failure means inadequate pumping of the blood by the heart. So in this case, the ventricle contract poorly, and that's why the ejection fraction will be less than 40. So systolic heart failure means inadequate pumping, whereas diastolic heart failure is impairment of the left ventricular filling, which means when the heart is not filling with blood, or you can say when heart is not relaxing enough. It should be suspected in an elderly patient with hypertension, but a normal heart size on chest X-ray, who comes to us with dyspnea or pulmonary edema. So we know that sometimes in a heart failure patient, we can get cardiomegaly in a chest X-ray. But in this patient who has diastolic heart failure, they don't get cardiomegaly. Okay, because the problem is not that heart is getting too much bigger in this case. The problem is that heart cannot pump, heart cannot get relaxed. So it becomes more shorter or smaller rather than getting bigger. The cardiomegaly is more commonly found in systolic heart failure because you know that in systolic heart failure, patient will develop left ventricular hypertrophy, right? So I was talking about it. And that's why sometimes the heart can look bigger on a chest X-ray. But in a diastole, the problem is that it can't get bigger or it can't relax. So in diastolic heart failure, usually the heart shadow will be normal. So that's also one of the clue to the examination that when to think of like systolic and diastolic heart failure. Sometimes a patient can have both systolic and diastolic heart failure at the same time as well. So how to confirm systolic and diastolic heart failure? So systolic heart failure, the confirmation is by doing the ejection fraction from a echocardiogram. The causes of systolic heart failure, ischemic cardiomyopathy, dilated cardiomyopathy, but most important is MI. And then there is diastolic heart failure. There are lots of causes of it. We will discuss that, but one of the causes is cardiomyopathies as well. So that one is like there is a restrictive cardiomyopathy that causes this diastolic heart failure. Okay, so causes of heart failure. So you can see in here that what are the causes of systolic heart failure. So now this is from John Murtagh, ischemic heart disease, including previous MI is the most common cause. Approximately 2/3 of systolic heart failure is caused by it. And also sometimes hypertension can cause this. Diastolic heart failure, risk factors are hypertension, diabetes. Even ischemic heart disease can cause diastolic heart failure. Hypertension, aortic stenosis, any of these can be the cause. Okay. So you understand about heart failure symptoms and signs. Now come to the investigation. Let's say you have got a patient, 60-year-old, coming to you with shortness of breath on exertion, ankle edema, tender hepatomegaly, and also raised JVP. What will you do next? What will be your next investigation of choice? Diastolic is ventricular filling impairment. So atrium is not very important for any of these actions or heart function. It's the ventricle which is more important. So think about what you would do in the real life scenario. Would you send the patient straight to a echo or would you do a ECG first? Yes, you would always do a ECG first. Even though it looks like a heart failure patient, we know that one of the common cause of heart failure is myocardial infarction. So what if this patient also have a MI and that has caused the heart failure? So definitely you need to do a ECG first. So the first test is ECG always. And then if they ask what is the confirmatory test or what is the best test, that is echocardiogram. We can do chest X-ray, but it is not our first or second test. It is an adjunctive test. So it's not actually an option to choose in the exam. Sometimes if echocardiogram is not available, we can do another test called BNP, which is B-type natriuretic peptide. Now, this is not a diagnostic test. It is more about prognostic test. So if a patient has heart failure and question asks, what test will give you the prognosis of this patient? That time we do the BNP. But there are some places like rural place where there is no echo available. In that case, we can do a BNP even to diagnose heart failure. But in exam, if echo is there, that is always the most definitive test. Can heart failure come immediately? It's not immediately, but if a patient has ongoing ischemic heart disease, or if a patient had a like a MI, but they did not even come to you, there are late presentation of MI. So the idea is that it's not about that it will come immediately after MI, but a patient can have underlying ischemic heart disease, and that might be the cause of heart failure. And that's why we do the ECG. Okay. And not all patients will come to you immediately after having a heart failure symptoms. They can wait for 10, 15 days before they come to you. They will only come to you when they start to get short of breath. But before they get short of breath, they have a lot of other symptoms as well. And some of them will not come to you. Okay. So diagnosis, we understand that echo is the confirmatory. We talked about others, so you can go through them. Management, very important. So a heart failure patient needs a very appropriate management for, for proper care and prognosis. So let's have a look. The first thing always for a heart failure patient, especially systolic heart failure patient, is ACE inhibitor. So ACE inhibitor or ARB, that is the first choice of medication for a heart failure patient. Okay. If a patient has heart failure and has fluid accumulation in their lungs, so if a patient has pulmonary edema due to heart failure, that is the time we add furosemide. We don't need to even add furosemide if there is just a little bit of pedal edema. So just because a patient has ankle edema doesn't necessarily we need to start furosemide straight away. Only time furosemide should be started straight away is when they develop the basal crepitations, when they have shortness of breath on exertion, orthopnea. That is the time you would start the patient with furosemide. So the first line is ACE inhibitor or ARB. Now let's say ACE inhibitor you have given, you have added a diuretic because they are congested. Then what? If a patient is stable in heart failure, that means patient has a stable heart failure or compensated heart failure or well-controlled heart failure, then we can add a selective beta blocker. These beta blocker are very important, so we can give them bisoprolol, atenolol, metoprolol. So these are commonly used beta blocker. Now, still after that, heart failure is not getting anywhere. The next option is aldosterone antagonist, which is spironolactone. So this is a step-by-step management. You start with ACE inhibitor or ARB. If having fluid overload, then add a diuretic. If a patient has a stable heart failure, add a beta blocker. But still, even after beta blocker, patient has a bit of symptoms, you can go for a spironolactone. We don't start beta blocker in a decompensated heart failure patient. Like a patient who comes to you with active shortness of breath, oxygen saturation is low. That means he is in acute left heart failure or acute pulmonary edema. That acute presentation patient will not get beta blocker at first. Once you make them stable, then you can start beta blocker for that patient. Okay. So spironolactone is not working. What else we can add? There is a medication called ivabradine. Very commonly we use nowadays, especially if the ejection fraction goes below 35% and patient is still not well controlled with this medication, we can use ivabradine. Even after this, still patient is in shortness of breath, heart failure is not improving, ejection fraction is still lower than 35. There is a new combination medication we use nowadays. Do you guys have any idea what is that called? Yes, so it is the Entresto. Entresto is a very good medication for heart failure patient, commonly used in Australia, especially as a last option when the heart failure or ejection fraction is very low and it's not getting better with the above medication. Entresto is a combination of sacubitril and valsartan. What is valsartan? Is it ACE or ARB? Yeah, ARB, right? So if you add Entresto in this patient, what would you stop from the above medication? Yes. So you started ACE inhibitor in that patient or ARB, same, like they work in the more or less same way. So if you start a patient with Entresto, you need to stop the ACE inhibitor, which is a very common mistake. Even a lot of senior doctors do the mistakes like that, because if you give valsartan and let's say you started the patient with candesartan initially, it can just cause a lot of problem. So you stop the ACE inhibitor that you started first, and then you start the patient with Entresto. What does this sacubitril do? What is the function of sacubitril in heart failure? So sacubitril is called, yes, ARNI, right? So it is a neprilysin inhibitor. And what it does is that it prevents the breakdown of that natriuretic peptide. So if it can prevent breakdown of that natriuretic peptide, it can actually help to relax the blood vessel. So when the blood vessel get relaxed, it puts less pressure on the heart because there will be a bit of peripheral pooling of blood. That's fine. But what it does that it reduces the strain on the heart. Okay. Okay. So there is another medication we can also add. That is not like that has you can start even at first when you diagnose a patient with heart failure. That is called empagliflozin. Empagliflozin is a SGLT2 inhibitor commonly used in diabetic patient, type 2 diabetes. So empagliflozin, it is the main use is diabetes, but in chronic heart failure patient, we can use the empagliflozin. And empagliflozin helps to prevent the chronic kidney disease in a patient who has chronic heart failure. So it protects the kidney. So it can be started even when you first diagnose a patient with heart failure. It is mainly preventative, yes, but it helps a lot as part of general heart failure patient. But it mainly protects the kidney from, from getting kidney failure, because one of the complications of heart failure is chronic kidney disease eventually. Okay, so let's not go into too much pathophysiology, but understanding the basic is important. So as long as you understand a little bit of basic that why we are giving this, it will be okay. So you start with the ACE inhibitor or ARB. If a patient has fluid overload, especially pulmonary edema, that is the only time we would add a diuretic. If it is a stable heart failure patient, we can add a beta blocker. We have got a lot of beta blocker like bisoprolol, atenolol, nebivolol, any of those we can start. If still patient is not getting like full benefit, have a little bit of symptoms, we can add a spironolactone. Spironolactone also usually added in a fluid overload patient. Okay. Then we have got ivabradine. Ivabradine is only indicated if the systolic or if the ejection fraction is less than 35%. In the same way, if ejection fraction is less than 35, we also start Entresto. And then we can always use the empagliflozin, doesn't matter, so you can use it initially as well. So step by step is this: ACE inhibitor, diuretics if needed, which is furosemide, beta blocker, spironolactone, ivabradine, Entresto. No, if a patient has got severe kidney disease, then we don't use empagliflozin because that's a problem also. So in up to stage 3B CKD, you can use empagliflozin. We also take action about the creatinine clearance. Let's not go into that, but yes, if it is a severe CKD patient, you can't add empagliflozin. The reason why we add empagliflozin is to make sure that a heart failure patient doesn't become a stage 3 or a stage 4 CKD patient eventually. And sacubitril, it's a complicated mode of action. It's not really needed for you. Just remember that it inhibits the breakdown of that natriuretic peptide. Natriuretic peptide is needed for relaxation of the blood vessels. And what it does that when there is lots of BNP available, it mainly helps to relax the blood vessels. It decreases the blood pressure. So it just makes like in one sentence, sacubitril reduce a strain on the heart. Okay, that's the main job it does. Empagliflozin is added in any patient who has heart failure. Doesn't necessarily that you have to start it when ejection fraction is less than 35. It can be used at any time because it mainly prevents the strain on the kidney. Yes, so if empagliflozin causes any kind of side effect, you will stop it. So a lot of things we consider when a patient has multiple comorbidities, like heart failure with asthma. Are we going to give a beta blocker? It depends on a lot of things. So as a doctor, there is no hard and fast rule that, yes, this is a asthma patient, we will not use beta blocker at all. We use beta blocker in asthma patient, but depends. If it is a mild asthma patient, very much well controlled, doesn't even need any kind of um, doesn't even need any preventer most of the time, that patient doesn't really have any problem. But if it is a severe asthma patient who has most of the time they are in a flare-up condition, then yes, we would not start it. So it depends on a lot of factors. Okay, so beta blocker is a very important part of heart failure therapy. Along with ACE inhibitor, beta blocker have been demonstrated to decrease mortality, reduce hospitalization, improve functional class, and improve ejection fraction. So this is one of the medication which has mortality benefit in heart failure patient, especially ACE inhibitor and beta blocker. Start a patient on beta blocker after stabilization of symptoms with diuretic and ACE inhibitor, irrespective of the blood pressure. So that's important. So patient who comes to you with acute pulmonary edema, you would not start a beta blocker immediately. You will give them ACE inhibitor, you will give them diuretic, make them stable, and then you can start beta blocker. Okay? And when a patient with stable heart failure comes to you, then you can add all of this. So ACE inhibitor, you don't need diuretic if it is a stable heart failure patient. You can start a beta blocker. Okay? So it depends on the stability of the patient and the status of the patient. Stable means when they don't have symptoms of heart failure. There are lots of heart failure patient who doesn't have any congestion, who doesn't get like shortness of breath a lot. So stable basically means that yes, I can walk. I don't have any pedal edema. I don't have any edema in my lungs. That means I'm stable. If a patient is like having shortness of breath, and you can visibly see that yes, he's having shortness of breath even when talking, that is an unstable patient. Okay, and stable means there is no more fluid. Maybe a little bit is fine, but when there is not a lot of fluid accumulation in the body, patient is able to do daily activities without much of a problem. Okay. Diastolic heart failure. So management mainly based on treating the cause. So if there is a hypertension, you will treat hypertension. So mainly treating the cause can help to improve diastolic heart failure. The problem with diastolic heart failure is that it can't relax properly. And if it can't relax, it can't take the blood in, right? So ideally in diastole, it will be relaxed like this. And then all the blood can flow into the heart. So you need to give something which can help the heart to get that time to relax. So if you can reduce the heart rate with rate limiting calcium channel blocker or beta blocker, when heart rate is reduced, heart is pumping slowly, so it is getting enough time to fill in. So in a diastolic heart failure patient, your main treatment will be beta blocker or calcium channel blocker. Okay. You can see ACE inhibitor, beta blocker, and spironolactone have been shown to improve survival in congestive heart failure patient. Most common is hypertension, then ischemia, then diabetes. So that's mostly all about heart failure. And if you understand up to this, you will be fine. Now, little bit about pulmonary edema. We discussed about how the pulmonary edema presents and everything. I will show you a picture. This is how a pulmonary edema X-ray looks like. So it is a medical emergency because this patient is in active shortness of breath and they can end up getting into a respiratory failure. So in a patient who has pulmonary edema, they can develop this bat wing appearance. So see this one. This is called bat wing appearance. So they get this kind of like interstitial shadow, or you can see this white opacity in the both lungs, looks like a bad way. And that is a very important chest X-ray feature of pulmonary edema. And we know that in pulmonary edema, patient might be a non-heart failure patient coming to you with increased shortness of breath, respiratory rate is very high. They are maybe even getting into cyanosis. There is bibasal crepitation, oxygen saturation has dropped. That is the time you think of pulmonary edema. The treatment is admission, start oxygen, and start diuretic, because diuretic can reduce this like excessive fluid accumulation. And then we can also give morphine to this patient, because morphine will reduce the anxiety, because when a patient can't breathe, they start to get very anxious, and morphine helps to calm them down. And definitely propped up position is important, and others like nitroglycerin, this can be given. But the main treatment is propped up position, oxygen, and diuretics. Okay. While we are talking about heart failure, there are some medications that we commonly use, right? So in exam, time to time, they will give you the side effect of common medication. Although pharmacy is not a part of the exam, but a lot of pharmacy related questions come in the exam. So pharmacology is an important part. Lots of side effects, drug interaction will be there in your exam question. So common drugs, you should know their complication and side effect. Like thiazide diuretics, complication, it can cause, everything can be low. So hyponatremia, potassium can be low. It can cause hypercalcemia, hyperuricemia, which can cause gout. So in gout patient who has like a lot of recurrent gout, we try to avoid thiazide. It can even cause agranulocytosis or pancytopenia. It can increase the blood sugar level. So these are common complications we should know of. Hyponatremia, hypokalemia, hypercalcemia, hyperuricemia, agranulocytosis, and impaired glucose tolerance. Indapamide also it works usually the same way, and the side effects are more or less same. Very common side effect of indapamide is hyponatremia. Loop diuretics, which is your furosemide. We also use bumetanide in Australia, so it's important to know. It can cause hyponatremia, hypokalemia, hypocalcemia. Okay, and furosemide is a ototoxic drug as well. So important to know. Spironolactone, this is the only one out of any of the diuretics that causes hyperkalemia. And also one of the very important side effects is gynecomastia. So these are the side effects that you are supposed to know. Okay, so remember what are the side effects of thiazide, indapamide, furosemide, and spironolactone. No, we should not use beta blocker and CCB together, because both can reduce the heart rate. Indapamide causes hyponatremia. Yeah, if we suspect pulmonary edema, we can do a chest X-ray, especially if you get bibasal crepitation, then yes, we can do a chest X-ray as first, because that will give us most of the information. Beta blocker is commonly used than calcium channel blocker. Empagliflozin can be used in any stage of heart failure. Okay, you must have heard about digoxin, right? So digoxin was used for heart failure for a long, long time. But nowadays, rarely we use digoxin in heart failure patient unless we really need to. Okay. The only indication of digoxin is, let's say a patient who has atrial fibrillation, and you have an atrial fibrillation got complicated with a CCF. You have tried beta blocker like metoprolol or any of those, but still heart failure is not getting better. In that case, you can give digoxin to the patient. So that is the only indication of digoxin nowadays. Okay, so atrial fibrillation or flutter plus a CCF patient. And if you have given beta blocker, so first line is always beta blocker. It's not getting better, especially the heart failure is not getting better, you can give digoxin to that patient. So why we stopped giving digoxin? There is a reason for it. So digoxin, the problem with digoxin is that it has a lot of side effect. So the common side effect is nausea, vomiting, gynecomastia, blurry vision, yellow halo around the objects. But the most problem is the arrhythmia. It can cause a lot of arrhythmic problem in the heart, like paroxysmal atrial tachycardia, premature ventricular complex. So lots of complications are there. Almost any kind of arrhythmia can be caused by digoxin. That's why, because of its side effects, and it can get accumulated in the blood and can cause toxicity. That's why we try not to give digoxin to the patient anymore. So if a patient develops these symptoms of digoxin toxicity, nausea, vomiting, yellow halos, blurry vision, the first thing we do is stop digoxin. And if it is really bad, that means patient is getting real side effect and like lots of arrhythmic problem, we can always also give a antidote, which is called dizibind. Okay, that can be given. Doesn't come in exam because this is not very commonly used anymore. So no need to go through too much for this. Next, medical device for systolic dysfunction. So there is a thing called automatic implantable cardioverter defibrillator. This is given in a patient who develops ischemic cardiomyopathy. So a patient who has ischemic dilated cardiomyopathy and their ejection fraction is less than 35%, they are the candidate who can actually have this cardioverter defibrillator. Why? Because this group of patients can go into sudden VFib, like ventricular fibrillation and cardiac arrest. So if they go into that, then this implantable defibrillator will shock the patient and it will just revert back to normal. So this is the only indication when this is given. All right. Any questions about heart failure? So the best investigation for pulmonary edema also a echocardiogram, because that's the time you would know the cause of pulmonary edema. But initially you can do a chest X-ray, then you can do a ECG, then a echo. In diastolic heart failure, we either give beta blocker or rate-limiting calcium channel blocker. We use thiazide diuretics in diabetes patient, but we need to make sure that it is not a patient who has very severely uncontrolled diabetes. In a controlled diabetic patient, we can use thiazide, but if a patient who has very uncontrolled diabetes, we would not use that. Entresto only used in systolic heart failure. Good question. If a patient develops bilateral edema after using amlodipine, amlodipine is a very common medication which causes this edema. The next thing we do that you can change it to another calcium channel blocker, which is called larcanadipine. And this is what we normally do in Australia. If amlodipine gives pedal edema, we change it to larcanadipine. And larcanadipine usually has less problem with these kind of things. If larcanadipine is not in the option, then you change the amlodipine to ACE inhibitor or ARB. Can questions from RNE come in exam? You should definitely know that, like, when to use Entresto because it is commonly used in Australia. So, but not too much rather than just knowing that Entresto is there. How to diagnose systolic and diastolic heart failure. So what we have done so far for this last 1 hour, we have been discussing systolic and diastolic. We are not going back. Okay, just there is no point of going back to the same thing again and again because it just wastes on like other people's time and we can't actually discuss the things which is important. So it is better that when we discuss a particular topic, if you just ask me at that time that, Doc, I didn't understand what is systolic and diastolic heart failure, that becomes very, very time effective thing because then we can just immediately repeat that. But after half an hour of the class, if someone asks that, what is systolic and diastolic heart failure, that's the time we feel like, oh, what we have done so far. So I would advise that just ask me when we're discussing that topic. So that will be more easier for us because we discussed systolic, diastolic for at least 30 to 40 minutes, right? There is no specific thing like a spironolactone can be only used after beta blocker. There is always a thing that can you start beta blocker in that patient? Is it a stable heart failure? If it is a stable heart failure, then yes, beta blocker first and then spironolactone. But if it is not a stable heart failure, you can't use beta blocker. Then you can bypass beta blocker and start a spironolactone if needed. So I don't know like why you guys are more interested about Entresto because that's not the first thing that comes in exam. Well, Entresto has, let's say, at least the sacubitril. Sacubitril will will take blood in the periphery. What is the problem with diastolic heart failure? Diastolic heart failure, the problem is that there is not much of a blood that heart is getting. So if you're already giving a medication which is pulling blood in the periphery, what will happen? The heart is not getting blood already, and you are giving a medication to pull the blood to the periphery. So it can make it worse. That's why Entresto has nothing to do in diastolic heart failure. How to differentiate on, you can't actually differentiate a systolic diastolic on a ECG. The echo can make the differentiation. If ejection fraction less than 35, that is systolic. If ejection fraction is normal, which means if ejection fraction less than 45, that is systolic heart failure. If ejection fraction more than 45, that can be diastolic heart failure. Okay, moving on to valvular heart disease. So valvular heart disease, the only thing that comes in exam from valvular heart disease is murmur. I think you guys are quite stressed with heart failure. Let's take a 5-minute break and then we start the murmur because I don't want to explode your brain today. Seems like I am. Okay, let's take a 5-minute break, have some coffee or tea, come back, and then we'll discuss murmur. How that sounds. And I might need some tea or coffee also. Okay, thank you. All right, everyone, let's start again. Good question, Dr. Charlie. So if patient has less than 35% ejection fraction, can I start ARNI immediately? No. You should first try with the first thing. ARNI is usually last option. But someone who's heart failure patient, ejection fraction 15%, 20%, then yes, we start ARNI immediately for those patients. But but 35, 30, even 25, like sometimes they will start with just ACE inhibitor. But when it comes to like 20, 23, even 25 sometimes, so it depends on a lot of factor, like presentation of the patients and everything. But when it's 20%, yes, ARNI can be started even without trying others. But when it is above 20%, below 35, then yes, we will go with the simple traditional way. Furosemide first. If pulmonary edema, furosemide will come first than anything else. Okay. Now, valvular heart disease. Valvular heart disease is important. There is no John Murtagh chapter for it. So we normally go with the med bullets. So there is two links that we have given in the portal. So you'll see that if you just know the type of the murmur in the common ones, that is all that you need for valvular heart disease in the exam. So it's kind of memorizing the murmur and what causes what type of murmur is important. Okay. So let's have an idea that what is murmur and all. So if this is the sternum, okay, so let's say this is second intercostal space, this is third, fourth, fifth, right? So let's say that's where the heart is. Okay, so if we see that, so let's say this is the left fifth intercostal space. And this one is, so this is left and that's the right. So we have got mainly four valves. That's important. Now we have got two valves in the right side, two valves on the left side. And I hope you remember all the discussions about the valves and all. So you have got tricuspid valve in between right atrium, right ventricle, mitral valve in between left atrium, left ventricle, and then we have got pulmonary valve there and aortic valve there, right? So these are the four valve, and out of these four valve, mainly the one that comes in exam is aortic valve and mitral valve problems. So as long as you know the murmurs related to aortic valve and mitral valve, you are good for the exam. But if you can remember a bit more, you can always go through the tricuspid and pulmonary, but we don't discuss that in the class. So where is the exact site of these valves? That's important. So if you look over here, mitral valve is usually located at the left fifth intercostal space. Then we have got tricuspid valve, or let's say aortic valve. Tricuspid valve is commonly the murmur of tricuspid valve is best heard in the left fourth intercostal space, along the sternal margin. So tricuspid valve, left fourth intercostal space. We know that mitral valve is left fifth intercostal space. So the tricuspid is more proximal to the sternal edge, whereas the mitral valve is mainly located along the a little bit distal to the sternal edge, usually 9 to 10 centimeter distal. Now, what about the other two, pulmonary and aortic valve? As you can see, the pulmonary valve, although it starts from the right heart, it goes to the left side, right? So that's why the pulmonary valve is best heard. That means the pulmonary murmurs are best heard in this left second intercostal space. And aorta, although it originates from the left side, but it comes to the right like this, right? So that's why aortic murmur, especially aortic stenosis murmur, is best heard on the right second intercostal space. The only anomaly is aortic regurgitation. Aortic regurgitation is best heard around the left fourth intercostal space, which is similar like the tricuspid. So although it is a bit unusual for the aortic regurgitation murmur, but there is the one that you need to just remember. So these are the common murmurs that comes in exam and we need to know about it. So when you know the location or site of murmur, sometimes it becomes easier to choose the right option of murmur. So again, mitral murmurs are best heard in the left fifth intercostal space. Tricuspid murmur best heard in the left fourth intercostal space. Pulmonary murmur best heard on the left second intercostal space. So it's not easy. So all of them are on the left. Only the aortic stenosis murmur, it's best heard on the right second intercostal space. Okay, is this clear for everyone? Like the site of the murmur? Great. Now that we know about the site of different murmur, let's talk about the specific murmurs. Now, I usually use a kind of like a trick to remember murmurs, especially the important ones. I remember only one murmur, which is the mitral stenosis murmur. And mitral stenosis murmur is a mid-diastolic murmur. And we know that mitral murmur is best heard on the left fifth intercostal space. So I only remember the MS, nothing else. And I can remember all others just by using a trick. So mitral stenosis is mid-diastolic murmur. Now, remember, we would only remember about mitral and aortic murmur because this is important for exam. And for the purpose of the trick, remember the opposite of mitral is aorta and opposite of stenosis is regurgitation. Again, just for the purpose of the use of the trick, opposite of murmur is aortic and opposite of stenosis is regurgitation. Why we would do that? So let's say this one, opposite of mitral is aortic, opposite of stenosis is regurgitation. So we have got aortic regurgitation. Aortic regurgitation also gives us diastolic murmur. And it's a bit different diastolic murmur known as early diastolic murmur. That is the only thing I need to remember. But I can easily know that these two are diastolic murmur. Now, what is left? We have got mitral stenosis, so we have left with mitral regurgitation. We have aortic regurgitation, so we still have aortic stenosis. This too is systolic murmur. Aortic stenosis is an ejection systolic murmur. So you can easily remember E for E. And mitral regurgitation is a pansystolic murmur or holosystolic murmur. Okay, and we know the site of this murmur. So if you can understand this, then it is very, like, you can easily find it out in the exam. You might need just 5 to 10 seconds. If you even forget in the exam that I can't remember what is this murmur all about, you can just use this trick and you will come to the conclusion and you will easily be able to come to the right diagnosis. So just remember mitral stenosis murmur, and then you can work out the other. Was it helpful? Like, did you guys understand how this works? Okay, so that's usually will help you to come to the right diagnosis in the exam. And exam already knows that like murmur is very difficult, so they would not give you like a complex murmur in the exam. Like Dr. Afia, multiple murmurs are mentioned in the question, then you need to focus on the which one is main one. Okay, so multiple murmurs are not always in every diagnosis. There are few which has multiple murmur. When we discuss the pediatric murmur, then you will get to understand which gives the multiple murmur, because pediatric ASD, VSD comes with multiple murmurs. Okay, if anyone can't understand murmur, then all you can do is to memorize. At least memorize these four, because these four comes in exam mainly. Okay, and in here we have also given all the important murmur types and everything. So you can see mitral stenosis is a rumbling mid-diastolic murmur, paced hard in the left fifth intercostal space. So it's all over here, so you can give it a read. Okay, but I don't normally need to remember anything if I can understand how to use this trick, because that's all that's needed for the exam. But if you want to memorize even the pulmonary and tricuspid murmur, just go for it. It's fine. It doesn't hurt. But don't confuse everything, because usually this four murmur comes in exam. Okay. And if you go to med bullets, in the med bullets, we have got lots of discussions about this. So you can go through this. So in the med bullets, they discussed about all the murmurs. So aortic stenosis, what is the type of murmur, where exactly it hurts best. So you can remember it, but this looks more tricky to me rather than what I already use. So it's up to you what you want to use, but mainly try to just remember what we discussed, and that should work for the exam. One of the other thing to remember from these two murmurs, one of aortic stenosis murmur and mitral regurgitation murmur, these two murmur radiates. So aortic stenosis murmur radiates to the carotid or the neck, and mitral regurgitation murmur radiates to the axilla. Okay. All right. So if you can remember those four murmurs, that's all that we want you to do. There is nothing you need to do. The management usually doesn't come in exam. Okay. So moving on to cardiomyopathy. Cardiomyopathy. So if we get some time, then we will come back to this murmur discussion again at the end of the class. Okay, but let's move on. We still have a lot of things to finish. So cardiomyopathy, in pregnancy, which murmur is common? any murmur can be common. It is in pregnancy, you get mainly systolic flow murmur because there is increased amount of blood flow. So that is the physiological murmur, but any murmur can be there. So it's not like pregnancy patient will have any specific murmur, but the murmur that they get is called systolic flow murmur. Okay, dilated cardiomyopathy or congestive cardiomyopathy. So now we are moving into cardiomyopathy, which means the cardiac muscle has got the problem. So there are three types of cardiomyopathy. First one is dilated cardiomyopathy. So in dilated cardiomyopathy, you can see that this is the normal heart and left ventricle usually a bit bigger anyway. But in dilated cardiomyopathy, you can see that it has got severely dilated. So when it gets dilated like that, it no longer has that elasticity. So when it does not have elasticity, it can't pump the blood anymore as effectively as it is supposed to. So it is characterized by diminished myocardial contractility. And if myocardial contractility reduces, or if it gets impaired, what kind of heart failure you would get, right? Systolic heart failure, right? So that's right, because in systolic heart failure, the contractility is the problem. So in this patient who develops dilated cardiomyopathy, your treatment is mainly to treat systolic heart failure because eventually this patient will develop systolic heart failure. So most common is idiopathy, but alcohol is one of the common cause as well. Could be myocardial infarction, could be myocarditis. So any of these can be the cause. So this dilated cardiomyopathy mainly presents with heart failure. So you will get all the heart failure symptoms, and the treatment will be just how you are treating a systolic heart failure. And mainly ACE inhibitor, beta blocker, spironolactone, those will be your treatment. So main treatment is to treat the heart failure. And what kind of heart failure? Systolic heart failure. This is not John Murtagh. Cardiomyopathies are not there in John Murtagh. So don't worry about things that we say that it's not like if it is a JM chapter, I will usually mention that this is chapter 30, chapter 35, like that. Like the chest pain chapter, when we discussed, we mentioned you, right? So if something is specifically from John Murtagh and it is important, we will definitely mention that during the class. If we don't mention it, it means it is not from John Murtagh. Likely it is from Kaplan Step to CK. And the other one is in pregnancy, no, it is not right, Dr. Jaman, that MS is common. MS is common if a patient has rheumatic heart disease. So a lot of patient has rheumatic fever, rheumatic heart disease, and if that patient becomes pregnant, yes, MS will be common in that patient for having a murmur. But pregnancy doesn't give you a MS. It's not like that, that a patient becomes pregnant and that patient will develop a mitral stenosis. Not like that at all. Yes, it can be exacerbated. So if already there is a valvular problem, then yes, then mitral valve problem can be exacerbated. And those usually happens in a patient who has underlying rheumatic heart disease. So there's a bit different thing. Like if we say that pregnancy causes MS, that's totally a very big mistake. That it doesn't. But pregnancy can cause an exacerbation of murmur of MS if there is already a valvular problem in that patient before become pregnant. Okay. So no, the dilated cardiomyopathy, understand the physiology, guys, because without physiology, you will end up just memorizing things. It's very easy to understand that dilated cardiomyopathy means the heart has got dilated, which means it no longer has that elasticity, so it cannot contract. If it cannot contract, means that the problem is systole. So it is a systolic heart failure. Okay. Now, the next one is HOCM, which is HOCM, hypertrophic obstructive cardiomyopathy. So HOCM can happen without any problem, like patient might not have any genetic issues, but 60% cases it is hereditary and it is an autosomal dominant inheritance, but not always. So in this case, the patient will develop unexplained myocardial hypertrophy, especially the interventricular septum will be very big. So this is the normal interventricular septum. In HOCM, you can see that it becomes very enlarged, right? Sometimes it gets really big enough that it can even cause obstruction of the flow of blood from the left ventricle into the aorta, because you can see that it's causing a bit of blockage there, right? So it can cause a bit of aortic problem as well, because it becomes so hypertrophied that it can cause a bit of blockage of the entrance of blood into the aortic valve. Okay, so the main pathophysiology in this case is hypertrophied interventricular septum and also the ventricular or the myocardium. So as you can see here, there is not much of a space in here. What will be the problem in this patient? Contraction or relaxation? What do you feel? Yeah, not contraction, because this is, let think about, this is a patient who is going to the gym, or this is the heart which is going to the gym and got a big muscle. So he can contract very hard. Some of these patients, ejection fraction can be 80 to 90% because all you can see here is muscle, right? So sometimes the contraction will be like more than normal in this patient. The problem is relaxation because it can't relax. It doesn't have enough space for the blood to come in even. So this patient will end up getting a diastolic heart failure. Okay. So as a result of the hypertrophy, left ventricular compliance will be reduced. But systolic performance is not the problem. The problem is inability of the heart to relax. So heart becomes hypercontractile. So because it has very significant muscular hypertrophy, the systole can occur with striking rapidity. Ejection fraction can go to 90%. So the symptoms in this case will be diastolic heart failure symptoms. So patient can get all the heart failure symptoms: shortness of breath, syncope, palpitation. They can get a beefy carotid pulse, S4 gallop rhythm. So these things can happen in this patient. One of the very important presentation for this patient is that this patient will say or come to you with sudden blackout or sudden syncope. So sudden loss of consciousness, usually in a young patient, can suggest, especially if the syncope happened very suddenly and patient regained consciousness also suddenly, that means it is a cardiac syncope. And one of the common cardiac syncope in a young patient, like 16-year-old, 20-year-old, was playing football, and then suddenly lost consciousness, and then they regain consciousness, and then they start playing again. So there was no confusion or anything afterwards. That is one of the questions to think, that what if this patient has got a hookup? Many times in the exam question, they will give you a clue that father died very early age, or someone in the family died early age. That is a clue to think that, well, it could be a HOCM. So all of these dilated cardiomyopathy, HOCM, the confirmatory diagnosis is echocardiogram, but you will start with ECG first. Some of these patients, if you do a resting echocardiogram, you might not be able to get the confirmation if it is a mild HOCM. So for those patients, you might need to send the patient for a stress echocardiogram, and a stress echo will be able to find out the HOCM. Okay. So if question give you a very classic history of HOCM patient, but they say that you have done an echocardiogram, it is normal, what would you do next? That is the time we would do a stress echo. So either patient will be exercising and then we do the echo, or we give dobutamine and then we go for an echo. Treatment. Treatment will be as if you are treating a diastolic heart failure, which means beta blocker or calcium channel blocker. Okay, clear? Another question, another cardiomyopathy is restrictive cardiomyopathy. Restrictive cardiomyopathy means that the cardiac muscle becomes totally rigid. When it becomes rigid and stiff, it can't do anything. So in patient with restrictive cardiomyopathy, the ventricle becomes hard, or the ventricular muscle becomes hard and stiff. So it can't contract, it can't relax. So it can't do anything. So this is the patient who can develop both systolic and diastolic heart failure. There is no specific therapy for this patient. Ultimately, patient usually dies from any kind of arrhythmia or heart failure. And the only thing that can cure this is a heart transplantation. Okay. It's the least common, and it's usually will not come in the exam. So these are all about cardiomyopathies. Just getting an understanding is all that you need for this. We talked about pericarditis last time. So pericarditis is the inflammation of the outer layer of the heart, which is pericardium. Commonly idiopathic, that means no known cause, then viral infection, connective tissue disease, sometimes even cancer, trauma, even renal failure like uremia can cause pericarditis. So you remember we discussed about how pericarditis pain looks like, and you do a ECG, you will get ST elevation in almost all leads, and the treatment in this case is anti-inflammatories or colchicine. Some of the patient who has pericarditis because of inflammation, they can end up getting a fluid around the heart or in the pericardial space. So if this is pericardium, this is heart, and this is the outer layer of the heart, which is pericardium. Normally, there should not be any fluid in this space, but because of inflammation, trauma, or lots of other things, they can start developing fluid there. That is called pericardial effusion. Okay? When the fluid will accumulate slowly, the patient might not have a lot of symptoms. But when more and more fluid start to build up, it can start causing compression on the heart. What will happen at that time? Heart will not be able to like relax, because everywhere there is fluid pressure. So they can't relax, and patient can end up into a heart failure again. So there is a condition called cardiac tamponade, where there is a huge amount of pressure in the pericardial space because of lots of fluid, and it starts to cause compression on the heart. Okay? And that's what we call as cardiac tamponade. It is a life-threatening condition because the fluid can develop very rapidly. There is a specific symptoms when we should think about it. So if you have got a patient who has got raised JVP, and then we have got a patient with muffled heart sound and hypotension. So it's called Beck's triad. So Beck's triad is associated with acute tamponade, low blood pressure, distended neck vein, and muffled or decreased heart sound. So if you have got a patient who is having shortness of breath, who is having orthopnea, and you have found that blood pressure is low, JVP is raised, and there is muffled heart sound, you should think of cardiac tamponade. Cardiac tamponade or pericardial effusion can be diagnosed by echocardiogram. Even a bedside echo can confirm it, and it needs immediate pericardiocentesis, which means a large bore needle will be inserted into the pericardial space, and you need to drain all the fluid or blood. Okay, that is the treatment. Clear so far? Any questions so far, guys? You are understanding everything? Pericardial effusion, cardiac tamponade. Good. Now, constrictive pericarditis. Not important for exam, but just to give you an idea that constrictive pericarditis is a condition in which the, the pericardium becomes thick. It can be because of any inflammation or anything. So the pericardium, so if this is the heart, an outer layer becomes very thick and rigid. What will be the problem? The problem is that heart needs to relax and it needs to get expanded to fill. When the outer covering is very rigid, it can't do that anymore. So this patient develops abnormal diastolic filling, and they also develop diastolic heart failure. Okay. Sometimes if you do a chest X-ray, you can see an eggshell appearance. Okay, kind of like see that this is all the calcium buildup in the pericardium, which is looking like this. Also, the treatment is symptomatic. Not much you can do about this anyway. Systolic is fine because you can still, the contraction is not a problem because contraction is happening. The heart muscle is not rigid, the pericardium is rigid. But the problem is that if heart needs to relax fully, the outer covering also needs to relax. That cannot happen in this case. Okay, next is hypertension. Okay, cardiac tamponade is very different than constrictive pericarditis. Constrictive pericarditis will come to you with like heart failure symptoms. Whereas in patient who has cardiac tamponade, they have different finding like their raised JVP, muffled heart sound, hypotension, and most importantly, cardiac tamponade patient will be very unwell. They will look very short of breath. So shortness of breath is like very bad in that patient. It's kind of an acute worsening of the breathlessness, and then you will get this muffled heart sound, which is not a very important feature of constrictive pericarditis. Constrictive pericarditis patient can have raised JVP because they can develop heart failure, but they would not have a lot of these symptoms. Yes, it can say that the heart sound feels like a bit distant because of this thick pericardium, but I would say that mainly you should think of like which one is coming to you with acute presentation. Constrictive pericarditis would not come to you as acute as a cardiac tamponade. Cardiac tamponade patient has like failure of cardiovascular system. They get severely hypotensive, which is not very common in constrictive pericarditis as well. So you don't get the hypotension part. Okay. No, muffled heart sound can be there in constrictive pericarditis because because of the thick pericardium, it might be hard to hear the heart sound. It's not the main thing. Main thing is the presentation. Constrictive pericarditis, it doesn't come as bad as a cardiac tamponade patient. On one of the other thing you should also look for that some of the patient with constrictive pericarditis, so some of the patient with constrictive pericarditis has this classic right-sided failure symptoms like ascites, jaundice, hepatic tenderness. So all the features of right heart failure comes very much evident in that patient. Whereas right heart failure is not the main presentation of cardiac tamponade, although there is raised JVP, your main presentation is acute shortness of breath in that patient. Patient will say, I can't breathe. Muffled heart sound is kind of like a distant heart sound, or it is difficult to hear. We can, Dr. Amina, yes. Sometimes if it comes back, we can do repeated pericardiocentesis, but otherwise, yes, we might need to do a pericardial window. Okay, moving on to hypertension, which is from John Murtagh 77th chapter in 8th edition. So let's go into that hypertension chapter. Hypertension is very common. All of you have some idea, but still in exam, you will get these questions wrong because everyone who comes to you with hypertension, you just start the medication. It is not the case in Australia. Not every hypertension patient will require a medication. Okay. So there is some specific guideline for it, which you need to follow. And these are like mastery question. If you get these kind of questions wrong in the exams, then chances of passing the exam gets very, very difficult. So definition of hypertension. So anyone above 18, we say that up to 139 by 89. That is up to this is high normal blood pressure. As soon as it becomes systolic above 140 or diastolic above 90 on multiple settings, then we can diagnose hypertension. There is mild, moderate, and severe hypertension, as you can see, based on the systolic and diastolic hypertension. So you need to just remember these values. So remember, severe hypertension means more than 180 systolic and more than 110 diastolic. Okay, so these values are important because management will depend on it. For adult above 18-year-old and above, hypertension is repetitive measurements of systolic more than 40 and or diastolic more than 90. Any of them high will be fine. Yes, you need to definitely, like, this is not like values. This is kind of like, even to manage a patient with hypertension, you need to know this. So causes of hypertension. So hypertension, 90 to 95% cases, there is no cause. And that is the essential hypertension or primary hypertension. 5 to 10% case, you can get a cause which is causing the hypertension, which is not very common. So some are kidney related, like glomerulonephritis, some patient with polycystic kidney disease, renal artery stenosis, that's one of the common cause. Then endocrine, Conn syndrome, Cushing syndrome, pheochromocytoma, this can cause it. Patient who use oral contraceptive, they can have high blood pressure, coarctation of aorta, some medication like NSAID steroid. So these are the common causes of secondary hypertension. Okay. So secondary hypertension is not very common. As you can see, only 5 to 10% cases. So we usually don't think of secondary hypertension unless there are some criteria. We'll talk about it. So when we would think of secondary hypertension, so sometimes in the questions, if they write that there is a renal artery bruit or abdominal bruit, then you can think of renal artery stenosis. Glomerulonephritis comes with hematuria, proteinuria, or RBC cast. Polycystic kidney disease will have bilateral kidney mass. So some of these features will help us to think that whether a patient can have secondary hypertension. Okay, but it's not very commonly given in the exam. And we will discuss all of these cases one by one when we have especially the endocrine. We will discuss this in the endocrine system, what kind of symptoms we get in Cushing syndrome, Conn's syndrome, pheochromocytoma, all of this will be discussed. But just remember that this can be the cause of secondary hypertension. There are two other names for hypertension. One is called malignant hypertension, another is refractory hypertension. So malignant is when diastolic blood pressure is more than 120. Along with that, they have some vasculopathy, like they have retinal changes, so hypertensive retinopathy or hypertensive nephropathy. So when it involves the end organ, which is your retina, kidney, and also have a diastolic more than 120, you can say malignant hypertension. Refractory, you have given at least maximum dose of 2 drugs and still blood pressure is high in 3 to 4 months time. That is the time we call it refractory hypertension. So refractory hypertension is one of the trigger to think of secondary hypertension. So we normally would not do all these tests for adrenal glands and everything for every patient who comes to us with hypertension. The only time we will order secondary hypertension causes is when we get this refractory hypertension, especially in young patient. So young patient having refractory hypertension, you will organize some blood test to rule out all the adrenal problems. You will do an renal artery duplex ultrasound to rule out renal artery stenosis. Okay, that is the only time we would do it, unless there is some specific physical examination finding. So renal artery stenosis, so if you see, this is the aorta, and that's the renal artery, and that's the kidney. Sometimes renal artery can have atherosclerosis, and it can become narrowed. If it is narrowed, then this kidney is not getting enough blood supply, and that can actually activate the renin-angiotensin system and can cause hypertension. So atherosclerosis is the most common cause of renal artery stenosis, whereas in young female or young adult female, fibromuscular dysplasia can be another cause. If we get renal artery bruit in physical examination, then we would order a Doppler ultrasound, which can confirm the diagnosis. In young patient, not only renal artery, we would also do the full adrenal panel. So you will check the renin-aldosterone level, you will check for Cushing syndrome. So you'll do the full adrenal biochemistry blood test. We will discuss those in endocrine, but in a young patient, you would try to rule out all the secondary causes one by one. And young means that ideally less than 40. Detection of hypertension, which is most important thing to know, not is if a patient just come and on a single visit, they have a high blood pressure, you can't just say that that patient is hypertensive. So diagnosis should not be made on the basis of a single visit. Initial raised BP should be confirmed on at least 2 other visits within the space of 3 months. So if first one is high, you need another 2. And if you see that average of that 3 visit, patient has got diastolic more than 90 and systolic more than 140, then you can diagnose hypertension. Clear? So total of 3 and you do an average. Blood pressure, so every adult above 18, we should check their blood pressure at least every 2 yearly. That's kind of a screening questions. So this is the management or the recommendation of follow-up. If a patient has got high normal blood pressure, which is this up to 139 and 89 diastolic, you will advise the patient to do some lifestyle modification and repeat the blood pressure in a year time. Now, this is the mild hypertension. You need to confirm the hypertension within 3 months, within 2 months. That means ask the patient to come at least twice in the next 2 months and then find out whether the patient is hypertensive or not. And still, for mild hypertension, lifestyle modification is the treatment. For moderate hypertension, at least make sure that you check the blood pressure and confirm the hypertension within a month. Advise the patient to continue the lifestyle. There will be management along with that. We will come into that. And in case of severe, you are supposed to evaluate the patient within a week. Some of these patients, you can even start the medication straight away. So this is actually about the follow-up, when you need to follow up for a mild hypertension, moderate hypertension, and severe hypertension. So mild within 2 months, moderate within a month, and severe within a week. If it is a mild hypertension, observation with repeated measurement over 3 to 6 months should be followed before beginning treatment. If any patient has an initial diastolic blood pressure more than 115 and has a target organ damage like vision problem, heart problem, kidney problem, then that is the patient you can start immediate antihypertensive. This is one of the patients who you can start antihypertensive without doing a follow-up. Okay, so if they say that they have got like retina problem or retinopathy, kidney damage, and diastolic more than 115, you can start treatment. There are some patients, you're doing multiple blood pressure reading. Sometimes it becomes very high and sometimes it comes low. Or when they come to your office, their blood pressure is very high, but when they go home, blood pressure is normal. When you have multiple discrepancy between this blood pressure, that is the time we can do this ambulatory 24-hour blood pressure monitoring. So you will give a device to the patient, which patient will put on for 24 hours. And then that device will measure the blood pressure whenever patient is working, sleeping, when the patient is awake, all the time. Like after every 10-15 minutes, it will check the blood pressure and it will give us the average blood pressure reading for that day. And that is one of the way we can confirm hypertension if in case sometimes it is very high, sometimes it is very low. Management. Management usually start with lifestyle modification. So we say that if it is a mild hypertension, non-pharmacological therapy for at least 3 months is ideal. And what else we can do for lifestyle? Most important lifestyle modification is to reduce the weight. Even if blood pressure is dropped, even if patient can drop 1 kilo weight, blood pressure can drop by 2.5 systolic, which is good. Reduction of excessive alcohol, reduction of salt intake, increased exercise, reduce smoking or quit smoking. So these are the lifestyle modification that we would advise a patient. Now, this is a good chart which will help you to diagnose or to manage a patient with hypertension. So let's say we have got a patient who is diagnosed as hypertension on several occasions. For every patient, lifestyle advice will be there. But sometimes to find out how much risk this patient has to develop a cardiovascular problem, we can do this cardiovascular risk assessment chart. Remember in one of the class, we have shown you like There is a cardiovascular chart where we can put the patient's systolic blood pressure and systolic blood pressure and cholesterol level, and it will give us how much risk this patient has to develop a heart attack in the next 5 years. So if a patient has low risk, then yes, we can continue lifestyle modification for even 6 to 12 months. If it is moderate risk, then 3 to 6 months. If after 6 months of lifestyle modification is still blood pressure high, then we can start a treatment. For high-risk patient, you can even begin the treatment immediately. Okay, so this is usually what we follow in Australia. So we confirm hypertension, and then we do the cardiovascular risk assessment. If the risk assessment shows patient is low risk, we are happy to continue the lifestyle modification for even 12 months. If it is moderate, then 6 months. If it is severe, then you can even start the treatment immediately. So what are the treatment? So treatment for hypertension start with any of the three. So any of these three is fine. You can try ACE inhibitor or ARB, calcium channel blocker, or thiazide diuretics. Thiazide diuretics usually commonly given as a first line in patient above 65. So you can start any of them if the patient did not get into the target blood pressure in 3 months, then you can start combining these medications. You can combine ACE inhibitor with CCB, calcium channel, ACE inhibitor with a thiazide, or ACE inhibitor with a beta blocker. Still, after 3 months, target hasn't been achieved, then you can combine all the three together. Still not getting better, you can add a spironolactone. Still not getting better, seek a specialist advice. Okay, so ACE inhibitor, calcium channel, thiazide diuretics, that's any of them can be your initial antihypertensive. And then you can do a double dose and even triple dose if needed. Do not combine beta blocker and calcium channel blocker because it can make it, the heart rate can go quite low. In the same way, try not to give, definitely don't give ACE inhibitor and ARB in the same patient because both of them work in the same way. Sometimes when you give ACE inhibitor and spironolactone in a patient, make sure to rule out hyperkalemia in that patient because both ACE inhibitor and spironolactone can increase the potassium. Okay? Making sense, guys, that what to do, where to start, when to start, what kind of medication to start? Okay. What is hypertensive emergencies? Hypertensive emergency is when high blood pressure causes presence with some cardiovascular problem. Hypertensive emergency can present as a encephalopathy, so patient is confused, stroke, heart failure, aneurysm, any of these. That means if a patient who has hypertension and they have got this organ damage, so it doesn't matter how much is their blood pressure. If a blood pressure patient, and ideally we say that if it is more than 160 by 110, but it doesn't really matter about the blood pressure, but more about when a patient with hypertension develops any of these emergencies or organ involvement, it becomes a case of hypertensive emergencies. So the problem with hypertensive emergency is that this is really, it can be life-threatening for some patient if we can't drop down the blood pressure quite easily. But we can't also drop down the blood pressure very fast. What will happen if we drop the blood pressure very fast? It can cause cerebral ischemia. So the blood pressure will drop suddenly and brain will not get enough blood. It can end up even a stroke. That's right. So hypertensive emergencies, ideally 180 by 110 or 20. So this is some blood pressure that we don't tolerate. So if you see a patient whose blood pressure is like that, either systolic more than 180, diastolic more than 120, and they have got any of this emergency symptom or organ involvement, that patient needs to be sent to the hospital urgently. And blood pressure should be reduced no more than 25% within the first hour, and then gradually reduce it down. For them, treatment is CCB and an ACE inhibitor. That is the starting treatment. If really needed, IV nitroprusside can be given, but it will be given in the ICU. So what is the difference between hypertensive emergency and urgency? So urgency is the same blood pressure. So let's say the blood pressure is 180 by 120, but there is no end organ damage. So when there is no organ damage or no organ involvement, that becomes hypertensive urgency. And emergency means blood pressure is higher than 180 by 110, 120, but they have end organ damage. Okay. Both of the patients usually will be sent to hospital, but for urgency, where there is no end organ damage, you can still try to reduce the blood pressure in a primary care setting, but you need to review the patient at least every 1 or 2 days so that blood pressure can be dropped. Okay. Now, this is a very important table for exam. It gives you an idea that what kind of comorbidities you need to consider before starting a high blood pressure medication. So if a patient has constipation, we try not to give calcium channel blocker because it can cause constipation really bad. In a bradycardia or heart block patient, we will not give something which can reduce heart rate more, like beta blocker or calcium channel blocker. Diabetes, better to avoid thiazide diuretics, and best will be ACE inhibitor. Hyperuricemia also, better to avoid thiazide, best will be ACE inhibitor. Renal artery stenosis. If it is a unilateral renal artery stenosis, we can start the patient with ACE inhibitor or ARB, and that is the best treatment. If it is a bilateral renal artery stenosis, then we would give the patient calcium channel blocker. If it is a patient with kidney disease like CKD, in chronic kidney disease, at least for up to stage 3 CKD, your first choice of antihypertensive should be ACE inhibitor or ARB. But when it becomes end-stage kidney disease, then we don't give ACE inhibitor anymore. Then you can give the CCB, calcium channel blocker. Okay? And that's usually what comes in exam. So end organ damage is, you need to know what is end organ damage. So you check the kidney by doing a kidney test. So renal function. You check the mental status to rule out encephalopathy. Check for any stroke. Check for any heart attack. Okay. Check the retina for any retinopathy. So you're just checking the end organ to make sure they haven't got any. Same in proteinuria with hypertension, ACE inhibitor is better. So ACE inhibitor is usually the choice in unilateral renal artery stenosis. In bilateral renal artery stenosis, you would give calcium channel blocker. Up to stage 3 CKD, we can still consider giving ACE inhibitor. But if it is stage 4, stage 5, then better to avoid ACE inhibitor. You would give a calcium channel blocker if needed. Okay. So that's mainly all about cardiology, guys. There is only one chapter, which is chapter 70 and that is the palpitation chapter. And palpitation chapter will be discussed along with the ECG class. ECG class is not part of the 2 weeks free session. It will be discussed in our course. Okay. So that's the end of tonight's session about cardiology. We will do a cardiology question solve class with you. And that's, I think, coming up next Tuesday or Monday. So have a look on the schedule. So make sure to finish this once if you can in this time period. But if you can't, that is understandable. We will go through some of the questions and show you that how theory can be useful in solving the questions. The class schedule has been given in the First Aid AMC MCQ group. So that's the Facebook group. So have a look over there. I think so that's where it is. So the class schedule is given in First Aid AMC MCQ, and you can see your next class is on. So we have got tomorrow, there is a question solve class. And then we have got 27th of January, we have got cardiology question solve. So these are the two more free sessions left for this batch. And I would definitely advise that please don't wait for this, because if you are joining the course, you should start making the payment. You can make the payment either using our portal, which is if you just write firstaidamc.com. And in here, you'll be able to see the AMC MCQ course details are there as well. So if you need to read anything or know anything, you can have a read here. And if you just press on subscribe button, then they will take you to this initial page where you need to write all your details, go to the next page, and they will ask you to upload some photos. And then they will say that, like, have you paid? If you have paid, then just contact us. If you haven't paid, then you can make the payment using, there will be a link there and you can make the payment there. Okay. No, these topics will not be covered in course again, because these are part of the course. And any payment will be by card. So usually online, Dr. Michael. Diuretics can be given in RAS, but it should be very, like, you have to regulate it. It's not the best. It is enough. For cardiology, whatever I discussed, it is more than enough for your exam. After this, when we start the course, we will start with pediatrics. Yes, in proteinuria, we can give ACE inhibitor as long as the kidney function is fine, because ACE inhibitor can help to resolve the proteinuria. So the access to the portal will be there until you pass. The video recordings will be for total 10 months. No, cardiology class will not be repeated. I'm not sure, Dr. Michael. Yes, I think, like, it is, we normally would not be able to add everyone's bank in the payment option. The payment option usually will take your credit card. So it is the credit card which is used internationally, and using that you can make payment for anything. Even for AMC registrations, for AMC portfolio, you will need that. No, psychiatry, we haven't finished yet. There's a lot to discuss. Yes, so you will get the recording of the live classes. So if you miss any of those, we would give recordings of all the classes that we are taking. There is a Telegram group for this group. We will add everyone after this free 2-week session is gone. All right, everyone. So Dr. Urmi will discuss those things. I think like this kind of questions, it is still a bit earlier to discuss in front of beginners. You are not a beginner. So for beginners, these kind of questions will be very tricky. Once we discuss few more theory, then we should discuss something like that. Okay. I know about that, like Pakistan does not have the Telegram working. I'm aware of that. So still we haven't actually done anything about it. So in case that happens, then there will be a messenger group available as well. So we will add a messenger group where you can also like talk to each other. All good, everyone. I hope you are enjoying the sessions. Keep studying, and hopefully everything should be fine. Thanks all. Take care.